Good evening, everyone, and let's just talk of metastatic gastric cancer. I have been asked to speak only on metastatic, so I will stick to that. And next slide. We start off with a case: 48-year-old gentleman, abdominal pain, early satiety, loss of weight, still performance status 1. Investigations-wise, hemoglobin of 12, albumin normal, upper GI endoscopy showing a gastric body ulcer proliferative growth. So it's a gastric body, not a G junction or something. Next slide. This is the biopsy done of that growth, and you can see it shows that adenocarcinoma well to moderately differentiated. For whatever reason, IHC are also done and also confirms that it is a adenocarcinoma. Next slide. So if we can ask, this is what a CT scan abdomen was done. Diffuse stomach wall thickening, multiple omental deposits, moderate ascites, a CT scan lung not showing any metastasis. A PET scan was not done at this point. So if I can start off with the surgeon, Dr. Ronak, next option in this case, patient usually presents to you, what would you do next? Dr. Ronak, are you there?
Yeah. Hello. Good evening.
Yeah.
So I guess PET CT is not done till now to know the multi-organ metastasis in this particular case.
Can you give us one slide, please? Yeah. PET scan was not done. CT scan abdomen has been done, which shows omental deposits, ascites, and the thickening of the stomach. And CT lung has been done, which is negative.
Okay. So basically, HER2 receptor analysis can also be done as it has some role in the HER2 positive metastatic CS stomach. Apart from that, PDL1 analysis can also be done. But over and apart from that, pardon?
In a patient who lands up with you with this, what would be your next approach? Would you do all these tests and refer to the medical oncologist, or would you refer?
Yeah, I will surely refer to the medical oncologist if he is not suffering from any sort of localized complaints such as pain, dysphagia, or anything like that.
Fair enough. Fair enough. In this patient, would there be any scope of going ahead and doing the surgery at some point of time, or is it metastatic disease like this would always be a only palliative treatment?
So basically, in metastatic CS stomach, I would prefer with the systemic therapy only, because even in the case of dysphagia or bleeding, there is role of either radiotherapy or concurrent chemoradiotherapy. And as far as the literature is concerned, with the recent Regatta trial, it is also proved that systemic therapy has the role over even the palliative surgery in patients with metastatic CS stomach. So if even though the localized complaint of this is not there, I will definitely refer this patient to the medical oncologist for treatment.
Perfect. I think that's the way to go, and definitely the hopes of hopeful hypertension should not be at least avoided in the stomach. As of today, that seems to be the consensus. Dr. Sandeep, your thoughts? What would you do next in this patient who has got a frankly metastatic disease, not thrown on a PET? So first of all, are you happy with the CT abdomen and chest, or do you need a PET in every case?
So I'm happy with the CT scan and whole body CT, like CT abdomen pelvis thorax. And if there is no financial constraints are there, I think you can go ahead with PET CT scan as well. And I think in my clinical practice, what I do is at least PDL1 and a HER2 you can do depending on MSI or tumor mutational burden. The NGS can be offered, but
do you do DMD on routine basis? I'm very curious because are we doing it on a routine basis?
Not routinely for each and every patient, but yes, HER2 positive for every patient.
Okay. Dr. Kalpesh, do you agree with that? HER2 and PDL1 or MSI, would you do it in all patients? Dr. Kalpesh? Okay. Dr. Ankit?
Good evening, sir. So actually, Dr. Ankit is in emergency. So if he is able to join, then he'll join soon.
Okay. Dr. Kalpesh, is he there? I can't see him as well. Okay. Dr. Arun, are you there?
So Dr. Aruna is also is on call with someone. He is also busy, so I am calling him, but he is not responding.
Viraj, are you there?
Hi.
Dr. Viraj, are you there? Hi, Dr. Viraj.
Hi. So yes, I agree with panelists.
Let's have what to do and what to not do.
So this case would start with systemic therapy, and the routine practice, what I do is HER2 MMR and PDL1, all three go by S3 on day one. And we start with systemic chemo, and depending upon the profiling, we add immunotherapy or trastuzumab. Having said that, surgical role
Fair
you
enough.
asked.
I'll come to next. I'll come to that next. Yeah.
No, what the surgical point which you raised to our surgeon is that since this is only peritoneal only disease, we have some evidence that if this patient goes on long with good DFS with systemic treatment, one could consider resection followed by CRS.
Okay. Okay. It's not a standard of care, I would say. Probably, like you said, long-term DFS is good. We might consider it. But fair enough. We'll keep that in mind. Very good. Any thoughts on mutational analysis or the CGP? That seems to be the new trend for everyone.
Yeah, so I don't do that in my practice on day one, but some point in time, usually patients get NGS tested.
Fair enough. So again, as a routine, I think in stomach at least it's not something we would insist on. If it is done, it's good. Probably we can do it as well. But in routine practice, you're not doing. Dr. Kalpesh, I think you've joined us. Great. What's your thought on this option? Metastatic CS stomach, frank metastatic, no doubtful, good penis, no bleeding, nothing requiring radiotherapy. So let's put all that aside. PDL1, HER2 new MSI, or would you go ahead and also do a CGP or a mutation analysis?
As of now, standard of care is PDL and
Next slide, please. So for the purpose of our discussion,
CGP and mutation will help.
Yeah, I got you. Okay. So in this patient, since we are specifically talking of immunotherapy, I am taking it as a HER2 new negative. Next slide, please. So in this patient, these were the reports. Can we have the next slide, please? Next slide, guys. Whoever is moving. Yeah. So as you can see, HER2 new is negative, and PDL1, the TPS is 30 and CPS is 40. Okay, so very high TPS, high CPS. Okay, next slide. So let me go back to my medical oncologist, Dr. Sandeep Kakkar. What's your first choice of first-line therapy? Yeah, you can go through this slide, all the options. Just go next. Yeah, very good. One slide back.
With the given.
Okay, so I've given you these options, Dr. Sandeep. How would you go ahead with this?
So I think with the given PDL1 high status or at.
Can't hear you.
Right. Sorry.
Yes, 30 CPS.
So I think
CPS of 30.
Yes, with the given CPS of 30 in a patient, metastatic patient with high PDL1, I usually start with the pembrolizumab along with doublet chemotherapy.
Pembrolizumab with doublet. Okay. Yes. Nivolumab plus doublet. Any thoughts?
So I think majority of the data that is available is with Keytruda, pembrolizumab along with doublet. It has shown a survival advantage as well.
So nivolumab, you have a couple of trials which have shown benefit. Adeno-CF for gastric, you have 648, which showed advantage with CPS more than 5 as well as more than 10. If you have Pembro, only one trial again, which is showing more advantage of more than 10. Dr. Kalpesh, your thoughts?
Both of them are relevant options. Nivolumab also we have like Capox with nivolumab. It has been used, and I think I've used in my clinical practice. I've used pembrolizumab more with. So that is why I selected this. But I think no particular specifications regarding why.
That's fine. Okay, Dr. Kalpesh.
So Nivo and Pembro both can be used. If I am using Folfox, I would use nivolumab probably. With surgical regimen, I will go with Pembro within second day.
Any reason for this? I am a little intrigued by this. So Capox, you will use Pembro and this Nivo. Why like that? Any particular reason? The cost is the same actually, almost both for both of them.
Nivo is given at 15 days interval and Pembro is 21 days, and so probably patient has not to visit frequently.
Nivo can be given with Capox at 3-weekly interval. It can be given with Folfox at 2-weekly interval. Both are approved indications, and this is Pembro is approved at 3-weekly with Capox. Viraj, your
Then I think
thoughts
Nivo
on
is
this?
Yeah, so I prefer nivolumab. We have several negative trials with pembrolizumab. I'm not very comfortable with pembro. 062, especially largest trial, was negative, even for PDL1 more than 10. So I'm more comfortable with Checkmate 649, where you have CPS more than 5. We have approval with Folfox and Nivo. And so my treatment would be number 2.
Very good. So just as an aside, anybody who doesn't afford immuno, which is a big population, definitely, would you still prefer use the doublet or a triplet? Is that debate over? Dr. Kalpesh, doublet or triplet? Non-immunotherapy.
if patient is very young and fit, then probably triplet is an option. Else, I will go with only doublet.
Okay, very good. Viraj?
Yeah, so young patient, heavy burden disease, we do use sometimes triplet, modified DCF or modified clot, but mainly it is Folfox.
Okay, perfect. Great. Next slide.
Trials, and as you can see, there are trials which are. Hello, can you hear me?
So I just wanted to point out, Dr. Vamshi,
Yes.
that Pembro has not shown any improvement in OS in gastric cancer. As you were referring to, more than 10 is for squamous cell esophageal cancer, not for gastric cancer. For gastric, 062 has been
Yes.
negative.
Yes.
So currently, as
Yes,
we
you're right.
speak, nivolumab is the only monoclonal antibody or immunotherapy which is approved in gastric cancer.
Sure, absolutely correct. You have pointed out correctly.
Yes.
The yellow boxes is showing some improvement here that is non-inferior to chemo in the PDL1 process subgroup. It is not shown a superiority. You are perfectly right in that point. It is not inferior, it is showing non-inferiority. So if you can believe in that or whatever, it does not improve the overall survival. But nivolumab has improved overall survival both in the first line in adeno as well as the squamous carcinoma. That's what you're saying, Viraj, right?
Yes, and Pembro has shown OS in squamous esophagus, not in adeno.
Very good. So these are all the trials when you have the first line, the maintenance, the second line, and the third line. And as Viraj was pointing out, not everything is showing benefit. So next slide. That really brings me to this whole discussion of when we should use immunotherapy and what is the benefit of it. Next slide. So let me ask the panelists again a hypothetical situation. You have PDL1 30 in this patient, which made things easy. Supposing you have PDL1 of 10, or you have PDL1 of 5, or 0 or 1. What would you do? So, Dr. Sajjan, what would you do in these cases? Because as has been pointed out, the approval is for PDL1 more than 5 for adeno-CA with nivolumab. No approval really for adeno. What would you do if it is 10? Is nivo still an accessible thing for you? PDL1 of 5 or PDL1 of 0 and 1? Would you still do immuno plus chemo? And before Viraj can point out, yes, all of these have been approved. Nivo is approved with everything, but the data for a PDL1 0 is actually not good at all. So, what is our practice? And then Dr. Kalpesh.
For PDL1 0 and 1,
Sandeep, can you hear me? I'm sorry, Dr. Kalpesh, I missed you. What did you say?
So for PDL1 0 and 1, I will not use immunotherapy. I will just use chemotherapy only.
Okay. Dr. Again, Sandeep, I think can't hear us. Dr. Sandeep, can you hear us?
Yeah, agree. I think for 0 and 1, I am not using it. Majority of the times, I think more than 5.
Only more than 5. Okay. Dr. Viraj, your thoughts. Approval has been there irrespective of the PDL1. I mean, I don't know on what basis, but
No.
you know, you agree or
So,
you
so they changed it, Dr. Vamshi. So initial, I agree. Based on the 649 data, if the BMS filed for any PDL1, and they got FDA initially for any PDL1. And so based on that, in India, they applied for any PDL1. But now FDA has changed their label for CPS more than 5 because 0 to 5 has a rate of 0.94. So which is absolutely no benefit. Unfortunately, they have not
in
changed
India?
it in India. So India is still they are giving PAP for everyone. But I was discussing with them, and they are okay if we say only for more than 5 because that's the truth.
Okay, they are lucky if you don't. Basically, if you don't write it, they can't do anything about it. They have nothing to say about it. But if you write a PDL1 of 1 and still apply for it, they still give you, which I think is not a very good thing to do.
Correct.
But
Correct.
anyway, that's how they are. But that's what the company is doing. The reason I brought this about is I have no idea why the initial approval was given in the first place, and then they changed it later on, and why they're still persisting with it in India. I think these are hassles which all of us face when we deal with immunotherapy in India at least. Next slide. So again, I am very curious about this whole immunotherapy dosing as well. Next slide. So the nivolumab dosing, as I was talking in the beginning, is for both 2 weekly. You give a 240 mg fixed dose, and with the full fox, if you give it K-fox, it comes to almost 360 mg. Now, I'm not sure because a lot of the patients are 50 kgs and 60 kgs. If you use 240 mg, it becomes almost 4 to 4.5 mg per kg, whereas the dose is actually 3 mg per kg. Uh, what is the concern with it? Because BMS will not give you a PAP if you use this dose, unless you use this dose. So, Dr. Kalpesh, your thoughts on it? I mean, is it the right dose that we are using?
So I don't know what to say actually, but uh, it's a tricky question, and I would like to use 3 mg per kg.
Okay, Dr. Sandeep, your thoughts? Have you had
Always
this problem?
after all
Because
in all.
no, I have this challenge. I have an 80-year-old guy who we want to give Nivo. He's 60 kg. I don't want to give anything more than 180 mg because 3 mg per kg. And they're forcing that if you give 3 mg or to give 360 mg. I am not sure that's the right approach. Dr. Sandeep, your thoughts on this? I think Dr. Sandeep is also not there. Dr. Viraj?
Yeah, so of course I cannot answer here. So you have to call me. I will tell you what to do. But I agree with you. This is
Okay,
completely.
let's not get into
Let's move
those
on.
kind of things. But seriously, what do you? I
No,
mean, what do you think
because
of this approach? Is it the right approach?
No,
you
it
can
is
speak
not.
whatever you want to speak.
It is not. It is not. But I'll tell you what I do.
Hmm.
Not here
Hello?
on phone call.
Yeah, that's fine. That's fine. Those are accepted things you can say, but I don't know. I am very unhappy with this whole dosing business because
Yeah.
what
So
40
so we all know, right, why the dosing is flat dose, right? We don't need to know. So there was an excellent paper by Dr. Goldstein back in 2019 where they checked pembrolizumab 200 milligram flat dose versus if they would have given at 2 mg per kg for lung cancer in United States of America. And they found out that if they Medicare had used 2 mg per kg instead of 200 milligrams, the amount of pembrolizumab that they would have saved was only $1 billion. Only $1 billion. It's officially there in JAMA paper 2019. You can see. So it's a no-brainer. We all know why there is a fixed dosing. Unfortunately, we have to learn how to sidetrack this.
No. I am a very scared person. I never sidetrack. As you also know that I am very scared with getting into trouble with anybody from insurance to BMS. So I don't do all those. But my other thing though, what about the low dose nivolumab? We are really now becoming comfortable with low dose in head and neck. I mean, head and neck, all of us, I guess, are using low dose nivo. What about stomach and other things? Any personal experience of anybody in the panel with a low dose immunotherapy?
So I have
Dr.
experience.
Kalpesh, have you used it? Yes, Viraj.
Yeah, especially in MSI high cancers. We have done, you know, 4 weekly, 6 weekly dosing of just single 40 mg. Yes, MSI high, but only MSI high. I'm talking about only MSI high because I'm not comfortable.
Not just
Yeah, with PDL1. I don't think so. PDL1 is a good biomarker. You know, like the winner biomarker. You still get a year, year and a
I
half.
completely agree with you. Perfect. So I can tell you my experience. I have used in probably 6 or 7 patients the full dose and the low dose, and 2 patients on low dose, both of whom are on the 8th or the 9th dose of nivolumab. And the ones that have used the full dose, unfortunately, haven't progressed that fast. So that's been my experience. Again, it's a one-off experience, but that's what it is. Right. What about the safety concerns? I mean, I am not very happy with this high dose of nivolumab because my safe right toxicity seems to be kind of different. What's been your experience with that? Do you also agree with this that 240, 360, or you never use that high dose? That's what you're saying.
I don't go beyond 240. 363 weekly is something I don't do.
Okay, very good. Next slide. So in this patient, so these are the recommendations for the reports, and as Viraj said, the approval is for this PDL1 CPS more than 5. Of course, you do have approval for in HER2 is different. Otherwise, you can just use the CAPOX or CAPSIS. Next slide. So in our patient, we went ahead and used only CAPOX to begin with. And later on, the second cycle, we got the PDL1 report, and then we asked the patient, discussed the option. He agreed to go along with the nivolumab. We added nivolumab from third cycle. So 2 cycles, he took full dose of nivolumab of 360 milligram, reasonably well tolerated. By cycle 3, he was complaining a lot of fatigue. And this is something which I've noticed with a high dose of nivolumab, very severe fatigue. 2 patients, both of them severe fatigue. And by the end of the 4th cycle, he had worsening abdominal distension, severe weakness, and worsening symptoms. Next slide. We did do a PET CT at this point, which showed that the report was showing again moderate ascites and diffuse caking. Look at a thickness of 36 mm and nodularity with lot of peritoneal thickening. Now, when we had a clinical progression and then we compared with the CT, there was a progression. So, progression within 4 cycles despite 2 doses of nivolumab. So that's what it is. Viraj, your experience with nivolumab in stomach, any personal experience? Have you seen this kind of thing happening?
Yes, this is not uncommon. There are patients, especially when we are adding nivolumab after 6 weeks potentially. So we were speaking a couple of days before that there was a moonlight paper, this ESMO, exactly asking the same question that can we add nivolumab from after 3-4 FOX, so let's say after 6 weeks or 8 weeks compared to starting from day 1. And surprisingly, they showed the same effect that one would always think that, right, I can always add from 3rd cycle, 4th cycle, and I would see the benefit the same, but it was not. And I was so glad they showed it in a clinical trial, randomized fashion, that you are better off starting from day 1. PDL1 just takes 4 to 5 days. So I tend to start day 1, if at all we are starting. But yes, this is not uncommon. And unfortunately, this patient will go on taxane or Cyramza.
Correct. So this is something which, again, my enthusiasm for IO in gastric is, to be honest, not very high. Whatever little experience I have with few patients, somehow results seem to be not fantastic, but that's what it is. Next slide. So in this patient, what next? Progression on first line IO, what next would we do? Viraj, you said IO, taxanes and Cyramza. So you're comfortable using Cyramza after IO?
Yeah, taxane plus Cyramza. Yeah.
Taxane plus Cyramza. Dr. Kalpesh, your thoughts? Taxane plus Cyramza or irinotecan or single agent taxane? Again, we don't have Cyramza data after IO, to be honest.
So there are no data, but that's the best regimen in second line. IO plus Cyramza.
Yeah. Okay. So I think continuing only chemo or continuing IO really doesn't make any sense, at least for this. And again, I think compared to what we used to think, this is not bevacizumab, where you continue beyond progression, change the backbone, and still get some benefit. IO is a different ballgame altogether, and at least no point in continuing beyond progression in any disease as far as I'm concerned. Next slide. So this patient, we did the same thing. We started on Paclitaxel carbo, also I added initially, then switched to using ramucirumab. There's some typos in this. Please don't excuse my uh, discharge summary, but this is what happened. We continued patient on paclitaxel and ramucirumab, added carboplatin for whatever reason. Patient was reasonably fit, so we added. 2 cycles later, peripheral neuropathy, changed to docetaxel and continuing docetaxel with ramucirumab. Next slide. Now, after 4 cycles, again, PET scan was done and it showed a stable disease with good clinical tolerance. Now, patient was clinically better, only mild increase in ability, but otherwise stable disease. So that's what it is. And this is the patient we are continuing to continue or give chemo plus ramucirumab. So one of the in fact the rare places the ramucirumab seems to be working. Normally doesn't work very well as such, but it seems to be working in this case. So next slide. So again, how often do our patients go for a third line? And what is the average overall survival for a metastatic gastric adenocarcinoma? Dr. Kalpesh, you can take these two, and then probably we'll wind up because we are running out of time.
So very few patients go on to third line. Probably we can use this single and capacitor or 5 that they might just try failing or something. But then survival is not much longer. Yeah.
Okay.
So we all know.
And Viraj, what's your average overall survival, would you say, in your gastric cancer patients?
So around 15 to 18 months is what we get for gastric cancer. Unfortunately, this person is going off way before that. Third line, I agree, it's less than 30 to 40% patients eventually end up in third line. But this is the importance of CGP. I would, by this time, I would definitely try and make a point that I have that report in my hand. I have also tried Rigo-Nivo after Nivo failure, and I've got success. So that is something which we can use, especially with so high CPR.
Listening to you, I've tried it, but in 2 patients it didn't work. So I have lost interest in that regimen. So that has been not a great experience on my side. Okay, next slide. So we are almost at the end. So what I just do is quickly, we have only 2 panelists left by now. Next slide. So just a quick question on the G junction and esophageal adenocarcinoma. Would you treat it the same way or a different way, Dr. Kalpesh? Same principles? Okay, Viraj, I think you're the last man standing by now.
Yeah. Yeah, I think so. Earlier today, Dr. Arun was mentioning that G junction and gastric cancer have different molecular profiling. I think so. If you take adenocarcinoma by TCGA, they are identical. So, as if they are metastatic disease, they have to be treated same. For locoregional disease, one could argue about radiation versus no radiation, but for metastatic disease, I don't think so. There's any argument.
Okay. Completely agree with you. Only difference between squamous and adeno, and again, squamous probably again the whole the CPS cutoffs and those things will matter, but otherwise it's probably the same.
Correct.
Overall, personally, good thing. Yeah, go ahead, Viraj. Go ahead. You were saying something.
No, so yes,
Okay.
and second line
So,
IO, if we have missed due to some or the other reason, we can always provide second line. We have PAP also in India now. This is where, so it is very interesting, in second line, they would allow you to do 3 mg per kg. And in first line, they would not. It's ridiculous. I hope EMS is not listening to us.
unfortunately, I think they will be, even if they are, I don't think it matters much because unfortunately they take the discharge summaries as well nowadays. So, that is a bigger challenge for all of us. So, anyways, I think this was an interesting discussion again to see that where we are. And honestly, though IO has made a difference, definitely it's not the same like in a lung or somewhere else where it makes a significant difference. So that's my bottom line. And thanks to the audio, to the panel. So over to the organization.
Thank you very much, everyone, for this wonderful talk. Now we are going to start our next session.